Okay, good. Okay. So today, guys, is not a lecture. Today is a tutorial. And as everyone may guess, tutorials are very challenging over Zoom, but we're going to try our best. So tutorials mean interaction between the presenter and the audience, and we'll try to keep it as interactive as possible. We understand the challenge, but I think and I believe we will overcome it. So we will go over some cases and some clinical questions, and I would like you guys to try to participate as much as possible, okay? Okay, so this is the objectives of today's lecture. I need the chat somewhere. Okay, so kindly always when you are reading about the subject, read the objectives around the subject first so you can master it and understand what the course needs from you to know. Okay, so we'll start with case number 1. So we have a 26-year-old male presented to the emergency department with 1-day history of dyspnea. Dyspnea, shortness of breath, they all the same. His past medical history is significant for bronchial asthma. His medication, he is taking inhaled corticosteroid, Alvesco, 160 microgram daily, as well as PRN salbutamol, or famously known as the Ventolin. His allergies in the past were toward dust, so he is allergic to dust. His history of present illness is as of the following. 1 week ago, he started to have an upper respiratory tract infection symptoms. That's meaning something like rhinorrhea, sore throats, nasal congestion, all considered as upper respiratory tract infection symptoms. After a positive sick contact, his nephew was sick having similar illness. Then he started to have worsening dyspnea. So dyspnea, it's considered as lower respiratory tract infection symptoms, not upper, as well as occasional dry cough, no other respiratory symptoms, no cardiac symptoms whatsoever. His review system was negative. Okay, so how would you approach and manage this case? So what's next, guys? So you already went over the past medical history, the history of present illness, review of system, his medication list, his allergy list. We all went through it. So what's next? Come on, guys. I'd like you to attempt. What's next in your mind? What do you like to know about this patient? صحصحوا معانا يا شباب. Okay. History, we already went through it. Physical. Okay. What's physical signs you are looking for? So tell me what you want. I will provide it. Okay, fever. So you're looking for his temperature. Good. What else? Wheezing from stethoscope. Okay, so wheezing in lung examination. Good. What else?
Uses of accessory muscle.
Uses of accessory muscle. Good. Shortness of breath, that's in the history. So we already know that based on his presentation. He came to the emergency with dyspnea, and we said dyspnea, shortness of breath, they both are the same. What else?
Respiratory rate.
Okay, respirate. Okay, good. What else?
Saturation.
Oxygen saturation. Okay.
Pulsus paradoxus.
Pulsus paradoxus. What's that mean? someone will asking, someone saying coughing, that's in the history. So now let's focus in the examination. And always, guys, and this is a general rule in medicine, not even internal medicine, in medicine in general, always be systematic, okay? So when you say, I would like to do a physical examination, you always want to be systematic. Something like, okay, I would like to start with general appearance. I would like to check the vitals. Then I will go to the examining the chest, looking in the inspection of using accessory muscle, looking in the percussion, hyperresonance may indicate pneumothorax, for example, auscultating, looking for wheezing. So always be systematic, okay? But let's go back to one of the suggestions. Someone say, I would like to check him for pulsus paradox. What does that mean? In practice, how do we do it? Okay, someone mentioned here.
There is a
Pulsus
pathological
paradox.
decrease.
Say that again.
Pathological decrease in systolic blood pressure during inspiration, which is around more than 10 mercury.
So how is that in practice? Someone in the chat say pulsus paradoxus is a variation in the BB. I would say this is the blood pressure. So maybe they just flipped the two letters in both arms. Good try, but no. So how can we do the pulsus paradox test in physical examination? How? Eats the hands? No, maybe you didn't eat your breakfast yet. I don't know what eats hands meaning. Okay, guys. So the way you do the pulsus paradox is as of the following. So when you go to check someone's blood pressure manually, okay, so you basically inflate the cuff. So you go up in the blood pressure till you don't hear the blood flow. I hope you guys know that by now. So you put stethoscope below the cuff and then you inflate till all the sounds disappear. Okay, that's meaning you actually went above the systolic blood pressure. Okay, and then you deflate. تبدأ تفك شوي على الcuff. Deflate a little bit till you hear the blood flow in the stethoscope. Okay, so if you pay an extra attention, you will notice the following. That's okay, I hear the blood flow, so you can ask the patient to take inspiration and expiration. You're gonna hear it in both. So you're gonna hear a continuous blood flow. At that time, you're gonna inflate the cuff again, okay? Just raise it above a little bit, okay? One by one, like just 2 millimercury per 1 second, and then ask the patient to continue taking a deep breath. At one point, you're gonna hear the blood flow only during expiration, okay? So the difference between the blood pressure only during expiration, the blood flow, and during the whole respiration, inspiration, expiration, that is the pulsus paradox. And more than 10 millimercury considered to be abnormal. Good, okay. So let's continue in the case. So in general inspection, you're gonna try to find the following. What's his mental status? Is he having syncope? Does he have seizure? Because hypoxia and CO2 retention can cause all of these three. You're gonna focus on the respiratory distress. Is he actually using his accessory muscle? Is he able to speak and finish, let's say, 5 or 4 word sentences, or he just answering yes or no because he is out of breath? All of these are indication of severe asthma or status asthmaticus in general inspection. And the vital signs, someone already mentioned the fever. So that may indicate an infection triggering the asthma. The tachycardia, because the body is trying to compensate, and this is happening with severe asthma or status asthmaticus. Elevated in the blood pressure or hypotension. So elevated in the blood pressure from the stress the body is going through. Hypotension when he started to have basically a lot of air trapped inside his chest. Tachypnea, well, like increasing in the respiratory rates from exacerbation. Hypoxia, someone mentioning that, and especially in asthma. If you have someone asthmatic and they are hypoxic, they are in a big trouble. So pay a special attention to those people. Usually mild and even moderate asthma, they don't present with hypoxia. But when they come with hypoxia, they are actually severe. And we already talked about pulses paradoxes. In the chest examination, we're going to try to hear wheezing. And initially, you're going to hear it in the expiratory. Then you may hear it in both inspiration and expiration, okay? If you hear a silent chest meaning you hear nothing in the auscultation when you put your stethoscope in the chest, that's a dooming sign. That's meaning there is no air go inside the lung, no air going outside the lung. That's meaning it's dead end. So this is actually indicating that this patient gonna collapse soon, okay? Hyperresonance, when there is a lot of air entrapped inside the lung, and decrease breath sounds, okay? Okay, so back to our case to see which are of the signs we found them in examination. So no change in his mental status. He is in respiratory distress, using accessory muscle. That's not using his accessory muscle, my apology, and able to finish sentences with 5 words. So the general inspection was a little bit reassuring. Vital signs show the temperature of 37.2, heart rate of 94, blood pressure of 134/82, respiratory rate of 24, so he is tachypnic, saturation is 92, so he is in the lower side of normal. Chest, inspiratory and expiratory wheezing, no other sounds. The rest of the examination was unremarkable, okay? So how would you proceed to manage this case, guys? And when we talk about management, we are talking about 2 things at the same time. We are talking about investigation and we are talking about treatment. Okay, someone mentioning spirometry. What do you mean by spirometry? You mean the pulmonary function test? As I told you guys, this is a tutorial, so we're gonna take our time. I'd like to hear from you. What's in your mind? How would you manage this patient? What kind of investigation you request for him? Assume that you are actually the doctor in the emergency department. So you already did your thorough history taking. You are already did your thorough physical examination. Now it's the time to do the management, investigation and treatment. So, and usually they are actually, you will do it together. And this is why we say it's a management. But for the sake of today's tutorial, we may start with the investigation and then we're gonna talk about treatment. So one of your colleagues mentioned pulmonary function test. And if you guys remember from last week lecture, we say clearly that pulmonary function test, it's not a test done in the emergency setting. Pulmonary function test is an outpatient test and rarely even done for an inpatient. If it is not convenient for them to come to the hospital again, you may end up doing PFT for an inpatient, but it's not an emergency department test, okay? ABG, good, arterial blood gas. And what you're gonna look for in the ABG? Yeah, Mu'taz. So what's abnormality you may expect in someone with asthma exacerbation in their ABG? I will give you an example. If I have someone with sepsis, I would expect them to have a metabolic acidosis with a low pH, low bicarb. Okay, saturation of the oxygen, that's a good thought. Although that you can find it actually in the oximetry, but you may find the partial pressure of oxygen in ABG, and that's more accurate than the oximetry. Respiratory alkalosis, okay? So that's meaning you would expect the CO2 to be low, and then the compensation okay. Okay, so far those are a very good points. So pulse.
Chest X-ray.
Chest X-ray, good. Okay, so someone mentioned the ABG, and they would expect an respiratory alkalosis with a low CO2. Someone mentioned the partial oxygen pressure and the ABG, and now someone suggested a chest X-ray. And for each investigation, you will have to justify why you are ordering these tests. What are you looking for? Because if you don't know what you are looking for, probably you will not gonna find it. So what are we looking for in a chest X-ray? Okay, someone mentioned blood. Yeah, you want to say something?
Yeah. To exclude other differentials like pneumonia and pneumothorax. Okay. And usually a pulmonary mild to moderate is usually normal in asthmatic patient.
Good thought. So excluding other causes are a very valid reason to do a chest X-ray, as well as looking for trigger. Don't forget, this guy is starting to have a lower respiratory tract infection symptoms. So he may, in fact, have some consolidation or pneumonia, because don't forget, usually pneumonia can be preceded by a viral illness. So we call them bacterial superimposing the viral infection. Someone mentioning blood, IgE, excellent. And I would like them to rationale the IgE, but probably they're looking for IgE eosinophil asthma, and CBC looking for, you always have to rationale even the simple test. So just to make it short, CBC looking for leukocytosis, for example, or anemia, because anemia also can present with shortness of breath. Someone mentioned collapse, probably looking for the chest X-ray, hyperinflation. Yeah, those are all reasons to have a shortness of breath in people. Okay, so let's proceed. So reasonable investigation, chest X-ray, we talked about why, looking for trigger or other explanation for the shortness of breath. We talked about arterial blood gas, and we're gonna talk about the finding shortly. Peak expiratory flow meter. This is not a pulmonary function test. This very simple device is basically to test the peak expiratory flow. And this is, as you can guess, it's a carry-on test. Some patients, they actually have it with them at home. And the way they do it, it's basically they blow as much as possible to see what's the volume and the expiration. And usually they will know what their best numbers. So for example, let's say some patient, Mr. X, his best is 300. So one day he felt out of breath and he did this peak expiratory flow at home, and he found it to be at 150. That's meaning he's at 50% of his best peak flow, and he should go to the emergency department. While let's say he just felt a little bit uncomfortable, he did the peak expiratory flow and it was again 310. Better than his best. That's meaning probably there is another explanation. Okay. CBC, looking for leukocytosis, looking for anemia, creatinine. With all medication, we need to know the kidney impairment so we can adjust the medication, or sometimes it's even contraindication. ALT, the same. It's a marker for liver diseases. So you may end up adjusting or avoiding certain medication if you have a liver disease. And nasopharyngeal swab, that's for viral illness, including the pandemic now, the coronavirus. Okay, so someone, I'd like them to volunteer and tell me what they see in this chest X-ray. Is it normal or abnormal? And if there is any abnormality, please point it out. Okay. Okay, normal, yeah. There's no abnormality in the chest X-ray. Okay, good. Okay. How about this ABG? Anything abnormal or this is all normal? ABG. Okay, guys, I need some answers. What do you see abnormal? Someone mentioned abnormal oxygen. Yeah, the oxygen is in the lower end of normal. That's correct. What else? The blood is acidic. It's leaning toward the acidity, yes. Okay, guys. CO2 is lower than normal. That's correct. And this is something we're actually expecting in someone with asthma exacerbation because they are actually ventilating too fast. So they basically washing out their CO2. And this is actually very interesting. And we're going to spend some time here because of the following. Okay. So in someone actually with asthma exacerbation, there is phase of CO2. Okay. The first is actually when they are basically hyperventilating. So that's meaning they have a normal oxygen and they have low CO2 because they are washing out their CO2. So this is stage one. The second stage is basically you will have hypoxemia as well as low CO2. Okay. And then the third is basically when you started to see normal CO2, okay? So when you started to see normal CO2, this is actually a sign. This is an alarming sign. So this is something normal, but when it is normal, we're going to start to freak out, because that's meaning this patient is starting to tire. This patient is starting to not able to hyperventilate, okay? And when you started to see the CO2 high, elevated, that's meaning you have to freak out, because this patient is tiring, and this is a sign dooming that he will require intubation and mechanical ventilation. Is this clear, guys? So basically, in someone with exacerbation, we would expect the CO2 to be low because they are hyperventilate. When it is actually normal, this is an alarming sign. And when it's actually elevated, we have to freak out, because that's meaning they are going to respiratory failure soon. Is this clear, guys? Very important clinical point. A lot of people, they miss this point when they, especially when they see that the CO2 is normal. Okay, so this is one of those things. When it's normal, it's abnormal. Okay, so his white blood cell was 13 with elevated neutrophil. The rest are within normal range. His peak expiratory flow was 50% of his predicted or personal best. I'm just gonna explain what that means. Predicted, based on age, gender, as well as sometimes the weights, and sometimes even they take the height in consideration, there is a predicted peak expiratory flow. So it's like an equation. Okay, if this is your age, this is your gender, this is your height, this is your weight, your predicted peak expiratory flow is 400. But what's better than that is what we call it personal best. That's meaning when they are asymptomatic, when they have no symptoms, what's their best peak expiratory flow? And we'll put it as their best, the marks of their best, okay? Okay, so back to our case. How do you proceed managing and treating this patient, guys? What shall we give him? He's still in the emergency, sorry. ABC, okay. I kind of burned that card, okay. So ensuring he's protecting his airway, that he have a breathing and his oxygen, CO2 are lower than expected, as well as ensuring circulation. Good, what next? Oxygen first. So what you want to do? You have a real patient in the emerg. We are going beyond theory now. What you want to do? ABC, خلاص, we talked about ABC. He's protecting his airway, he's breathing, circulation as well. Okay, bronchodilator, salbutamol. Okay, how? Through IV? Through mouth? Again, you guys are not being specific. Give oxygen. Oxygen through nasal cannula, oxygen through face mask, oxygen through intubation, through BiPAP. There is tons of ways to give oxygen. IV lines, okay, so you're gonna secure IV lines, good. When someone mentioned inhaled, I'm gonna assume inhaled inhaled bronchodilators, that's good. So what are the bronchodilators? Someone is saying it's depend. Oh, guys, we are talking about one patient, huh? You already have his vitals. That's his vitals. His 134 over 82. His respiratory 24. Saturation is 92. temperature of 37.2. So we have actually a real patient here we're talking about. So if you think this is unstable patient, please tell us what you would like to do. We're talking about this patient. Okay, so beta-2 agonist, okay, salbutamol, inhaled salbutamol, okay. And someone mentioned inhaled steroid, good, okay. What else? So let's say you gave him the inhaled corticosteroid, you gave him the inhaled salbutamol, you secured an IV lines. What's next? Okay, let's proceed. So ABC we talked about, bronchodilators we're talking about salbutamol, and those are the doses. Is it important to know the doses? I think at that level, I think it's reasonable to know them, صراحة. We're not going to bother you in the exam about the doses, but it's good to know them. Asthma and COPD, both are a common disorders in our community. So know them by your heart, okay? So you give 100 mic of MDI puffs every 4 hours. That's around the clock. So every 4 hours plus 1 PRN. You may consider actually salbutamol nebulized instead of the puffs, as well as ipratropium, also known as Atrovent, 20 microgram MDI puff every 4 hours around the clock, as well as every hour PRN. You can also consider them through nebulizing, okay? Steroid, you would give prednisone, 0.5 to 1 milligram per kilogram daily for, I would say, from 5 to 14 days. Also, you can consider it as IV. Does all the patient with asthma exacerbation need systemic steroid? Probably yes, if they presented to the emergency. In the clinic is different. If you are like a family doctor or you are an internist or respirologist, you see them in the clinic and they have mild exacerbation, you may get away with inhaled. But usually when they comes to the emergency, usually they are in a severe condition. How about if they are refractory case, they haven't responded to the above mentioned intervention, or they are going to a life-threatening situation like status asthmaticus, you should consider giving them IV epinephrine, IV salbutamol, as well as magnesium sulfate, okay? Okay, so back to our case. So you give them the salbutamol, you give them nebulized salbutamol, you give them ipratropium nebulization, and you give them methylprednisone, let's say 0.5 milligram per kilogram. What's next, guys? What's next? The nurse is asking you, okay, we did all of that, doctor. What shall we do next? Excellent. Re-evaluation, reassessment, very key, very important in those exacerbations in the emergency, because we would like to determine, does this guy need an ICU? Does this guy need actually hospitalization? Or this guy can be discharged home? Excellent. Okay. So checking his clinical response, may consider repeating the ABG2. Okay. So patient starting to feel better. His vitals become as of the following: 36.8, 75, blood pressure is 125/70, risk rate of 14, saturation of 99%. His repeated peak expirative flow is at 80% of predicted or personal best. So patient was discharged home from the emergency with the following: He was asked to continue in the inhaled short-acting Ventolin, continue inhaled corticosteroid, continue the oral steroid for 7 days, patient education. You reviewed his medication, including inhaled technique. And this is very important, guys. Whenever you are prescribing an inhaled medication, make sure that your patient know how to use them, okay? Because if they don't use them right, they are not going to get benefit from them. Review the action plan. Action plan meaning if this gets worse, what shall they do? Shall they call a phone number? Shall they come back to the emergency? Shall they increase the inhaled corticosteroid through the puffs? And then offer a close follow-up. Don't send them just loose. You should see them in the clinic or with their respirologist in a couple of weeks. And review vaccination history, very important in anyone with lung disease, whether asthma or COPD, and ensure it's up to date. Okay? Question, guys. Anyone have any question before we move to the next case? Any question about asthma?
If we need to put the patient on oxygen, which type of oxygen? Modified oxygen or?
Modified oxygen, nasal cannula, that's okay. But if you're going to give them, let's say, nebulizer, if you're going to give them Ventolin, nebulization, it's better to give oxygen and nebulization at the same time. Someone asked, why we are doing ALT and AST. Just ALT is enough, just to know if they have an ongoing liver disease, because don't forget, a lot of medication, they will need a dose adjustment if they have a kidney or liver disease. Okay, any other question, guys? Okay, let's move to the next case. So we have a 55-year-old male presented to the emergency department with 1-day history of dyspnea. His past medical history is significant for COPD, diagnosed 3 years ago. His last PFT showed an FEV1 of 40% of predicted. So he already entering the severe COPD category. He is a heavy smoker. He is in what we call a triple inhaled therapy. He is an inhaled corticosteroid, long-acting beta agonist, long-acting muscarinic antagonist. He is allergic to penicillin. His past medical history, significant for, his history of present illness is 1 week ago, he started to have a worsening dyspnea, increase in the amount of sputum and change in the color, as well as cough. He was feeling feverish. His review of system is otherwise negative. So how would you approach and manage this patient? So what's left after the history? It's the physical examination. So what kind of signs we're gonna try to identify and find in the physical examination in someone with a possible COPD exacerbation? Okay, cyanosis, excellent. Parallel chest with a B, excellent. Speak,
Cough.
I am speaking, but okay. Inspection for mental status, good. What else?
Cough.
Coughing. Cough is a symptoms, so you would see it in the history, and he already complained about that, but also you may witness it during the examination. Okay, ability to speak, inspection for mental using accessory muscle. All of these are very good, mashallah. Good, good. Pursed lips, excellent, excellent. Okay, and don't forget the vitals, huh? Okay, so general inspection, you may try to find change in mental status, syncope, seizure, coma. They sometimes come confused. This is all can be related to CO2 retention or hypoxia. Respiratory distress, exhaustion. Don't forget, he came with 1 week history of shortness of breath. See me, he actually exhausted and tiring from the hyperventilation he's been doing. Use of accessory muscle, inability to speak. Okay, good. Vital signs, you may see fever, tachycardia, elevated in the blood pressure or hypotension, whether it's from the stress related, that the elevated blood pressure, or from hypotension from sepsis, tachypnea, hypoxia. All of these are vital signs, abnormality you may expect in someone with COPD exacerbation. In examination, you may see barrel chest, just indicate a state of COPD, decreased cardiac dullness, and basically because when you have a lot of air entrapped inside the lung, you may find that relatively the cardiac dullness and percussion may have shorter than an overall chest. Wheezing and maximum laryngeal height less than 4 centimeters because the laryngeal is being pulled in by the lungs. Pulses paradox more than 15 millimercury and decreased breath sound and using of accessory muscle. Okay, so we are going back to our patient. He is in a respiratory distress. This is when you examine him. He's using his accessory muscle and barely able to finish sentences with 3 words. That's alarming. His vitals showed a temperature of 38.9, febrile. His heart rate is 102, tachycardic. His blood pressure is 105/65. He is having hypotension. His risk rate is 28. He is tachypnic. His saturation is 80%. He is hypoxic. His chest examination showed inspiratory and expiratory wheezing, decreased air entry to the left side with a coarse crackles. The rest of examination was unremarkable, but there is a lot of red flags in this guy physical examination, okay? So how would you proceed to manage this case? ABC, absolutely. ABC, 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 ABC. And there is a lot of red flags in physical examination, okay? A lot of red flags. We're talking about being in respiratory distress, using his accessory muscle, unable to finish 3 words. His all vitals are abnormal. Those are red flags for you to push for ABC. So you move this patient to monitor bed. Let's call it, for example, if you are in the emergency, you put them in the resuscitation area, okay? And you have to secure the airway. You may end up even intubating those patients, as well as ensuring the breathing under the oxygenation, okay? So this guy, most of the time, guys, in the emergency, they will immediately put them in what we call it BiPAP, if they are able to breathe. If they are conscious and able to breathe, they put them on BiPAP, okay? And ensuring circulation. So you have to secure IV line, and you may end up giving them fluid because they have a low blood pressure, okay? Okay, so airway, ensuring he is protecting his airway. And this is mostly by ensuring that he is conscious. Breathing, need oxygen supplementation, non-rebreather or BiPAP. And circulation, ensuring he have a 2 large peripheral IV cannulas, okay? Okay, investigation and management should be happen together. He is a very sick patient, okay? Okay, so investigation, sorry, I jumped to the gun here, but we'd like to do a chest x-ray. What we are looking for in the chest x-ray, guys? Tell me. The nurse is asking you. In the requisition, there is a mandatory field that the Department of Imaging asking why you are doing a chest X-ray, hyperinflation. That's reasonable if someone is being worked up for COPD. We're talking about someone with COPD exacerbation. Excellent. Consolidation. That's excellent. We are looking for basically pneumonia or consolidation as a trigger for his COPD. Again, the barrel chest, the hyperinflation, they both are expected X-ray in COPD, but they are not telling you much about an exacerbation. Okay, and by the way, barrel chest is actually a physical examination finding, not a chest X-ray finding, while hyperinflation is a chest X-ray finding. Okay. Okay, so consolidation, I think that's a very reasonable reason for the chest X-ray. Arterial blood gas. What are we looking for in the arterial blood gas, guys? Come on, guys. I need your help. Excellent. Respiratory acidosis is from CO2 retention. Excellent, excellent. Okay. So we'd expect the CO2 to be in the rise. Okay.
It's type 2 respiratory failure. Yeah?
So say that again.
Type 2 respiratory failure.
If you have CO2, yes, but this guy may have mixed actually because he's also hypoxic. Huh? So he may have both, but you are absolutely right. It can be type 1, can be type 2. Blood acidity, CO2, oxygen, and bicarb. Excellent. Okay, yeah, those are the components of ABG, but I meant what the abnormality we would expect with someone with severe COPD. Okay, creatinine, ALT, AST, as we talked about previously, a lot of medication need adjustments if they have kidney or liver disorder. BMP and troponin is just, there is a lot of, sometimes people with dyspnea, they will present with the heart failure, look like COPD exacerbation, and this is why we sometimes ordering the BMP and the troponin, okay? Sometimes the clinical picture is so close to each other that other workup may help us out to differentiate between the two. ACG, of course, anyone with shortness of breath or chest tightness with this age group, we should do an ECG, sputum and blood culture. Okay, so how would we treat this patient, guys? Because don't forget, you're gonna order all of these investigations, but at the same time, you have to treat him, okay? He's very sick. So we treat and investigate at the same time. Always, guys, imagine you are the emergency doctor. Like, I always find it useful to put myself in the shoes, like in a kind of reality, and see what investigation, what management I will provide. Excellent. Oxygenation. Oxygen. Tell me how. BiPAP oxygen, that's excellent. Securing IV line, that's excellent. What else? So you put him in BiPAP, including oxygen, you secure IV line, what next? And he already in a monitor bed. So
short-acting anticholinergic.
Okay, so someone say short-acting anticholinergic, and someone mentioned inhaled corticosteroid. Okay. What else? What else?
Beta agonist.
Beta agonist. Good. What's nursing is asking? What's beta agonist meaning? What's the medication?
Albuterol, يا دكتور.
Huh?
Albuterol.
Okay, albuterol. Okay, salbutamol, albuterol, or famously known as Ventolin. Excellent. Okay, so bronchodilators. That's what we're talking about here. Excellent. someone is suggesting antibiotic if the patient is infected. Guys, we are not talking about يعني COPD. We're talking about this patient. المريض هذا اللي عندنا، هذا اللي قاعدين نتكلم عنه هذا. So would you give him antibiotic or would you not? We already put him in monitoring bed. We already started him on BiPAP. We give him a bronchodilators in form of albuterol as well as inhaled corticosteroid. So someone mentioned after CBC, we give antibiotic. Why after CBC? Why after CBC? Okay. Okay, probably you are confusing between the CBC and the blood culture, okay? So we usually prefer to take the blood culture before the antibiotic exposure because it may sterile the blood. So we're not gonna know what's the bacteria inside the blood. So if we can, in a reasonably time, just to send the blood and then starting the antibiotic right after, that's reasonable. If not, don't wait for the blood culture to be drawn. This guy is very sick, so antibiotic should be given as early as possible, okay? Okay, as well as IV steroid giving his COPD history. Okay, so ABC, salbutamol, nebulization, ipratropium, nebulization, methylpred through IV, antibiotic, levofloxacin. And why we are giving him levofloxacin? Why we didn't give him, for example, peptazo with ceftriaxone? Because he is allergic to penicillin. Good, prophylaxis, excellent. And don't forget to involve ICU because he is very sick. The antibiotic role in COPD exacerbation, they used to say, give antibiotic if any two of the following criteria are met. Increase in sputum purulent, increase in sputum volume, worsening dyspnea. This patient have, I think, increase in sputum purulent as well as the dyspnea. But now they are saying give antibiotic when there is a sign of bacterial infection are present. So it's more simplified rule, okay? Okay. This is his chest x-ray. What do you guys see in his chest x-ray? Increased consolidation in the lower left side. There is a consolidation in the left lower side. We don't have to say increase. You know, consolidation is abnormal in chest x-ray. Okay, so there is, you're right, consolidation in the left lower side. Lung hyperinflation, yes, there is hyperinflation. Flattening, diaphragmatic flattening. You may, يعني, as a sign, you may see a flattening of a diaphragm in COPD, but in this patient, there is not. يعني, this is a nice curving diaphragm on the right side. In the left, there is a lot of haziness من الconsolidation, so we cannot judge. But the right side, it's a very nice curve here, but a good thought. Okay, so we have consolidation in the left lower, but also there is a hyperinflation indicating just a state of COPD. Okay, so this is his ABG. How you guys interpret this ABG? What do you guys see? We just did an ABG last week, so you guys should be mastering ABG interpretation by now. Respiratory acidosis, good. Acute or chronic? Blood acidosis, respiratory acidosis, good. واحد يقول chronic واحد يقول acute. Okay, that's good. Always good to do the exercise. So first, there is acidemia. There is also hypoxemia. You see the partial oxygen is low. You see the CO2 is the retention 40, but the bicarb, let's say the normal is 40, now it's 80. And then the bicarb is 28. So it's only elevated by 4, so acute. So the body didn't have the time to compensate, okay? Okay. So you really have, after providing those intervention, you really have to closely follow the clinical response. This patient is very, very sick, guys. When you have all of these vital signs are abnormal, that's meaning by all definition, he's a sick, he need to be in monitoring bed, okay? Okay, so after you provided that, after 30 minutes, patient become drowsy and confused, agitated. He is removing his BiPAP mask. His ABG repeated showing worsening hypercapnia with acute respiratory acidosis. His medical team decided to intubate him and admit him to the medical ICU, okay? Okay. After 10 days, patient is stable, he's off oxygen and ready to go home. What are the long-term managements can be implemented to help this patient? So someone with COPD, what are the long-term managements? Come on, guys, I need your help. We don't want this patient to come back to the emergency with another severe COPD exacerbation. This may actually really lead to death. Excellent. Smoking cessation, that's an excellent idea. Pulmonary rehab, that's an excellent, excellent idea. So pulmonary rehab, smoking cessation, those two major intervention can be provided. Good. What else?
Pneumococcal influenza vaccine.
Excellent. So vaccination have to be up to date. Example, annual influenza vaccination. Also pneumococcal vaccination. That's excellent. Long-term oxygen therapy should be considered in someone hypoxic. And there is actually criteria when to provide long-term oxygen in someone with COPD. Okay. Excellent. So, but if they are hypoxic, they need to be on oxygen. Like if they are at baseline hypoxic, they need to be on oxygen training. Excellent. That's part of the rehab. Excellent. Excellent. Okay. So smoking cessation. It's the only intervention actually can slow the decline of FEV1. Okay. Review and ensure good buffer inhaler technique. Again, the same with asthma, the same with COPD. Vaccination have to be up to date, pulmonary rehab and exercise training. Okay, guys, time for question. Anyone have any question? Guys, question? Okay, guys. Thanks for participating. Guys, this is a tutorial. This is